morning. So after you've seen what to do, what not to do, primarily based on the bone and the metal, always consider there is a little bit of soft tissue around it. And of the soft tissue today, I'll just talk about how to avoid, and if you do end up doing something wrong, how to manage a tendon injury. And please remember, this is just pertaining to the interventions that you do for the distal radius fractures and not just pure tendon injuries. Today, the learning points will see how to avoid them, how to diagnose them, how to treat them if you have it, with different approaches that you're using and with different implants that you're using. The commonest implant that we use is a wire, and I'm sure a lot of people still use. There are a few tips. Don't just push the wire through the skin from wherever you're putting. This we learned from our seniors. Make a small stab wound, use a small mosquito forceps, dissect it down all the way to the bone, make a small, say you're putting a 1.2 millimeter wire, make a 2 millimeter width of soft tissue tunnel, put the point of the wire on the bone and then start drilling. Don't just push it through. There are multiple tendons and nerves around the distal radius that you may end up injuring or capturing. The other thing is you can use smooth tip wires instead of threaded wires so that you don't catch the tendons. One of the mentors had told us to use the initial pass that you do, use an oscillating mode rather than a high-speed drill mode. But in thicker bones, you may end up needing a high-speed bone. The commonest tendon that you can capture is when you're passing a radial styloid wire, you can end up injuring the extensor pollicis longus or the first compartment muscles. When you're passing a dorsal wire from the ulnar side to the proximal side, you may end up damaging the EDCs. So these are the two common tendons that can be affected when you're using the wire. So try and follow the little tips so that you can avoid it. Coming to the main approaches, everybody does a volar approach. I'm sure everybody does it. So for somebody who's already doing it, this could be a revision. For somebody who's starting off, this could be some important points to keep in mind. The volar Henry's approach, you can always get into the FCR right away. So go superficial, dissect it down through the sheet step by step. Don't just plunge your 15 number blade. You may end up splitting the FCR. But the commonest injury point for an FCR is this right at the corner of the distal corner of the incision, is where you're trying to fix the bone, but you're not able to kind of get in there. You're not seeing the distal fragment, and you're trying to extend the instead of extending the incision, trying to extend the cut in the FCR sheath, and you end up snipping off the FCR. So always remember, do good big incisions if you're not able to visualize it. It will help you in preventing any soft tissue damage. Because if you're not able to see in the depth where you're putting the plate, the other tendons that you can capture underneath the plate is the FPL and the finger flexors. This commonly happens when you've got a nice view of the distal fragment, but you're not seeing the proximal part where you're putting the proximal most screw. You may end up catching the FPL, and we have had cases that we get referred to. So big incisions or decent size incisions where you're able to see the fracture completely. The second thing is the position of the implant. Now, everybody talked about the watershed line. Now, the implants have been designed to be placed at a particular point in the distal radius. So use the right implants at the right position. So that the plates on the left are supposed to not cross the watershed line, and the plate on the right is supposed to cross the watershed line. So don't try to fix this plate in that position because you didn't have an implant, because you'll end up having something like this. Because the plate is proud, the flexors will keep rubbing against on it, and it doesn't happen on day one. It usually happens after 3 months, 6 months, and sometimes even after a year. So a volar locking plate is supposed to not cross the watershed line, and a rim plate is designed to cross the watershed line. This was what Dr. Warrier was mentioning, the Soomes criteria. This is actually tells us, basically it's a simple way to tell us that your plate is proud. There are 2 or 3 grades. I usually don't follow it because you know that if you cannot see the volar lip of the distal radius on a lateral X-ray, your plate is too proud. And this is what happens. If you don't use a proper implant, you will have a good reduction and a good X-ray, but you end up damaging the main tendons of the wrist, and that actually compromises the function. So proper incision and proper placement of implants. The third common thing that we end up doing is while passage of the screws. Now, always remember, when you're focusing on the volar side, there are enough number of tendons on the dorsal side that you may injure. And the commonest injury can be when you're actually plunging through while drilling the screw holes. Now, suppose you do end up plunging it, remember, don't spin it back. You can toggle it back so that you can reduce the chances of catching the tendon in your drill bit. And the commonest thing is the longer screw. So howsoever experience you get, you always have that thought in my mind, are my screws too long? And there are various ways to check it. The commonest ways is taking multiple C-arm views, going live and checking it. And the third view, or the commonest view that was recently developed, was what one of the seniors mentioned, is you flex the wrist on table. I call it a tangential view. I think there's a proper noun for that. Flex the wrist completely on table and shoot the way in which the C-arm is shooting. So you'll get an image like that, and it'll actually tell you whether the screws are long. What I've learned with experience is, if you feel the screw is long, the screw will be long. So if you want to sleep well, you can actually remove that screw and put 2 mm short. So don't hesitate in changing the screw, however confident you feel that your fixation is good. Because if you don't end up doing that, it does cause irritation on the opposite side. And the commonest tendon that gets injured is the EPL. So you'll end up doing something big on the dorsal side, which could have easily been avoided. So good incision, proper implant, positioning, proper implants, and proper positioning of the implants. The uncommon thing that we do miss is actually the screw heads. Now the plates are designed in a way where the locking screws will go all the way down and the cortical screws will stay slightly up. So ensure that all your screw heads are locked in. Otherwise, the flexor tendons will keep rubbing on it if the threads stay proud of the plate. There was a discussion on closing the pronator quadratus. It is possible to close it if it's intact. Now, one of the techniques is to obviously close in anatomical position, radial to ulnar. The other thing is, if you cannot do that, you can advance it a little bit proximal and close it to the capsular structures of the distal radius so that it covers the edge of the implant. Because the edge of the plate is something that will always cause a rupture of the tendons. Coming to the dorsal approach, I think it's one of the easier approaches for me as compared to the volar because everything is there. If you go slow, if you release the EPL first, and then dissect underneath the extensor tendons. So don't try and take the tendons out. As soon as you release the EPL, start cutting down onto the bone and elevate the extensors along with the periosteal sleeve underneath, so that you end up putting the dorsal plate on a bare bone. And when you cover the tendons back, you have a small sleeve of the extensor and the periosteum underneath the extensor tendon so that it can prevent irritation of the extensor tendon on the plate. I've not removed an extensor or a dorsal plate before up till now. Nowadays, the plates are quite thin. You have fairly thinner plates that contour well. The common indication to remove plate is the plate being too proud. Then in that way, there's no way you can prevent the extensor irritation.
Mohan?
Yes.
That previous slide, that Nikita said 2 dorsal plates. Where does she put the second dorsal plate?
So she can. You want to say? So there are 2 things. One usually here, one is usually here.
Sorry?
On either side. That's how it works. Now, suppose you have done a good job or somebody else has done a good job and the patient comes to you with some pain in the wrist or the fingers, weakness and crepitus. So that's probably your signal that something is wrong. And the commonest tendons that get injured on the dorsal side would be the EDC and the EPL. And the volar side would be the FPL and the long finger flexors. So pain, weakness, crepitus. If in doubt, try and do a resistance test because they may be able to move still in a partial tear, but the moment you try and do it against resistance, the pain generates. Get good x-rays if in doubt. Don't ignore these pains. It may not be just stiffness of the wrist, but it could well be an impending tendon tear, and you don't want to miss it. The first thing that you do is simple x-rays, get all views that are possible. And the commonest help the most important thing in my practice would be a good ultrasound. It actually tells us how good or how proud the screws are, whether the screws are actually rubbing against the tendon or not, and whether the tendon is complete tone, partial tone or not. Because this would be a key criteria to tell the patient that something needs to be done with the implant and something needs to be done with the tendon. So once you have diagnosed it, now comes the simpler part. Coming till the diagnosis was a difficult part. So either you change the implant if the fracture has not healed, so you can remove the screw, you can remove the plate, change the position of the plate, or if the fracture has healed, you can actually take the implant out. That's the simplest part. Again, for a tendon, there's nothing new. It's a completely different discussion. Whatever the tendon presents to you with, if it's a complete tear, you need to repair it. If it's a partial tear and the patient has a decent function, you can observe it, provided you have taken away the irritating implant. Now, if there's a complete tear and you're unable to repair it, you have two choices. You could use a tendon graft and reconstruct it, or better options would be to do a simple tendon transfer. So on the extensor side would be an EIP to EPL, because that's the commonest one and it's there on the dorsal side, and a long flexor fourth finger to the FPL. Now, this is just one example. This was a volar plate that was done. Looks quite innocuous. That's a post-op X-ray. But one of the screw was prominent because the patient presented to us with finger 3 and finger 4 drop. An ultrasound showed a complete tear. An intra-op showed a proximal, a screw quite long from the proximal end, but we ended up taking away the whole implant. She was an old patient. There was significant gap between the two tone ends. So we ended up doing a palmaris longus graft. We did it with Dr. Pankaj Ahire. So coming back to the learning points, it's how you avoid these complications is the key. Get good incisions. If you're not confident, don't worry about the length of the incision. Get a good exposure. Ensure that you're looking at all the tendons before and after completing the implants. If in doubt, get good x-rays, get an ultrasound to check whether the tendon is getting irritated or not. And don't procrastinate. The moment you feel there is something wrong, you please address it. Either you change the implant or remove the implant. Thank you so much.